BIMA, Bimanual Cataract Surgery, a 35-year experience from 1971 to 2006. An historical overview by Dr. Ong. The development locations were Bonn, 1972. The initial development and clinical application of the bimanual irrigation aspiration technology in congenital and soft cataracts. Tannhausen, 1973. Integration of BIMA technology in the extracapsular cataract extraction and iridocapsular lens implantations at the clinic of Dr. C.D. Binkhorst. Schiedam, 1975 to date. The integration of BIMA technology with the implantation of the capsular fixated retropupillary lens and the Ong capsular lens. And finally, Schiedam, 1992 to date, the integration of BIMA technology in the non-reciprocative mode within phacoemulsification surgery. Before we start with the overview, I would like to mention Professor José Barraquer from Bogotá, who initially raised the issue of bimanual irrigation aspiration at the end of the 60s. It all started at the University Eye Clinic in Bonn, Germany. 1971. It was in Bonn where we originally developed BIMA, a system for reciprocal and symmetrical irrigation aspiration of congenital and soft cataracts. The photograph shows my academic teacher and promoter, Professor Johannes Karl Müller, in Bonn. He founded this eye clinic. And this is his favorite surgical room number 1. In the early 70s, it was still common to perform bare-handed microsurgery. On the occasion of the German Ophthalmic Society Convention in 1971 in Heidelberg, I presented a paper about a new apparatus for a controlled bimanual irrigation aspiration technology for soft and semi-soft cataracts. My paper was delivered in 1971 and printed in 1972 in the Klinische Monatsblätter der Augenheilkunde. Setiawan Ong was my Sino-Indonesian composite name at that time, and in 1974 in the Netherlands I reverted to my original name, Ong. This is our microsurgical team in 1971 in Bonn, with Dr. Uwe Lippert at my side, driving the BIMA apparatus for a stable anterior chamber balance, and handling the efficient vice versa switching of the I&A functions. This is the typical bimanual posture, with 2 hands simultaneously working in the anterior chamber. Tannhausen, the Netherlands, 1972. I associated with the late Dr. Binkhorst and integrated BIMA into our routine extracapsular cataract extraction technique for his newly developed iridocapsular intraocular lens. We published this in the combined journals of the Dutch Ophthalmic Society in 1974 and 1979. BIMA and IOL, 1980. At the Charing Cross Hospital in London, on the occasion of the 6th Congress of the European Society of Ophthalmology, I reported about the Retro Lens 3, which is a retropupillary capsular intraocular lens in routine combination with bimanual irrigation aspiration. Afterwards, I had a personal discussion with the late Sir Harold Ridley and Dr. Binkhorst. In 1975, I settled in Schiedam, near Rotterdam. From 1975 onwards, BIMA technology was integrated in the local hospital in the implantation of our capsular fixated retropupillary lens and the Ong capsular lens.
The capsular lens, according to Ong, is an artificial lens, which is completely fixed in the posterior chamber of the eye by the remnants of the original crystalline capsule. This artificial lens occupies the anatomic position of the original lens. So the capsular lens has to be implanted into the posterior chamber in the remnants of the capsular pocket of the original lens. For this purpose, the usual technique for extracapsular cataract extraction was refined. The lens is grasped at the upper loop with the lens forceps. With its convex side down, it's then introduced into the anterior chamber. The large loop slides obliquely through the pupil towards the posterior capsule. In this oblique position, the loop, riding on the posterior capsule, slides further into the lower capsular pocket. The upper loop is then laid on the iris under the limbus. The second insertion maneuver is begun by introducing a blunt-hooked irrigating cannula. This fine hook, which is inserted into the fixation hole in the lens, can hold and direct the lens. Subsequently, an aspiration cannula is introduced, which shifts the pupillary margin upwards. With the irrigating cannula, the lens is first slid downwards and then to the center. Thus, the upper loop in turn rides upon the posterior capsule into the upper capsular pocket of the lens. After disengaging of the irrigating hook, the lens spontaneously centers in the remnants of the original capsule of the lens. The lens is placed at the correct depth with gentle pressure on the center. At the same time, carbachol is injected for adequate meiosis.
From 1990 onwards, in a renovated hospital, now called the Schieland Ziekenhuis, the implementation of BIMA in the sense of I&A technology with a non-reciprocative mode was realized in our general phaco emulsification clinic. These two BIMA I&A machines, with the efficient vice versa switch mechanism, were developed in our own labs in Schiedam. What is BIMA? BIMA, as the name says, is bimanual irrigation aspiration technology, with two hands simultaneously in action in the anterior chamber. It is based on two modalities. First, the reciprocal, which is the symmetrical mode. Secondly, the non-reciprocal, which is the asymmetrical mode. The field of applications. In the meantime, we have integrated this technique in congenital cataract surgery, in standard extracapsular cataract extraction with IOL procedures, in bimanual I&A during phaco procedures, in bimanual emulsifications during phaco, because phaco is basically an aspiration technology, and finally, in vitreoretinal procedures. For the symmetrical mode, which is irrigation and aspiration each on one side of the eye, and without the right to left and vice versa change of the instruments, in 1971 we developed the so-called BIMA switch apparatus. This is the lab in Germany, where we developed instruments. The BIMA switch apparatus was to avoid the right-to-left change and vice versa, and reinsertions of cannulas during surgery. It became motor-driven later on in Holland. Surgical application, first modality. The first basic configuration modality of BIMA is symmetry. Symmetry refers to instrument configuration. Symmetrical BIMA for congenital and juvenile cataracts was initiated in 1971. Symmetrical BIMA was also applied for extracapsular cataract extraction and IOL since 1973. Here we used the translateral, which means the right-to-left or vice versa switch apparatus. Leonhard Klein in Heidelberg made this model. Surgical application. The second modality is reciprocity. Reciprocity refers to anterior chamber volume balance. Reciprocal means that the volume of irrigation is identical to aspiration, for instance, with congenital cataracts. We published this during the Society of German Ophthalmology, the DOG, in Hamburg in 1972. Non-reciprocal means the volume of irrigation is greater than aspiration. To compensate for wound leakages, during the extracapsular cataract extraction and phaco procedures. The alternative in the early 70s. Since 1972, BIMA was my definite alternative to Charlie Kelman's monomanual Cavitron phacoemulsification. Kelman and his co-workers initially used the coaxial monomanual approach, which means irrigation and aspiration in one hand and from one side of the eye. Since 1972, the bimanual approach was consecutively done in all our cataract extractions on a systematic basis. So far, it has proved to be a safe and efficient procedure in almost all anterior chamber situations. Special surgical modifications. Non-curvilinear capsulorhexis. Since 1975, the systematic cutting of the anterior capsule with the capsular scissors gave a non-curvilinear capsulorhexis. In the next movie, you will see the two oblique cuts in the anterior lens capsule. Special scissors are used, resulting in this non-curvilinear capsulorhexis, which was safer than the tin can opener method, which was then very popular overseas.
Eventually, the two series of punctures are connected at both ends with the capsule scissors by means of two cuts, first left and then right, so that a large part of the anterior capsule is loosened.
The non-curvilinear capsulorhexis has proven to be sufficiently safe and efficient in combination with BIMA for capsular lens implantations in an era before the systematic use of viscoelastics. This is our basic extracapsular cataract extraction procedure between 1973 and 1992, combined with BIMA irrigation aspiration.
By means of bimanual aspiration and simultaneous irrigation of the anterior chamber with balanced salt solution, all visible cortex remnants are then removed. Finally, the posterior capsule is polished smooth. It is essential to remove all visible cortex remnants. The capsular pockets and the posterior capsule too should be entirely clean. Experience has shown that it is necessary, following complete toilet, to polish the posterior capsule for a short time, even if it appears clear. This further reduces the chance of the formation of after cataract. The implantation procedure comprises two insertion maneuvers in the anterior chamber, whose shape is maintained.
Phaco and BIMA since 1992, the transition of technology. After each phacoemulsification, we now use the second mode, which is the non-reciprocal and asymmetrical BIMA. These are the two asymmetrical cannulas, the larger one for irrigation and the smaller one for aspiration. We always begin sub-incisional, which means underneath the tunnel incision, with the aspiration cannula or handpiece. We then use gentle, radial and tangential movements to safeguard the capsule and zonulae. And in so doing, we clean the first hemicircumference underneath the tunnel incision safely. The capsule is polished here and there, wherever necessary, and lastly, we use our own standard monomanual I&A handpiece for the counter-incisional side of the capsular circumference. This is a standard procedure.
The capsule is polished here and there, wherever necessary. And lastly, we use our own standard monomanual I&A handpiece for the counter-incisional side of the capsule equator. This is a standard procedure.
The mash-up method. With the BIMA technique, we can mash up all residual cortex between the two quasi-diametrical instruments. We do likewise while eating potatoes, don't we? I discussed this in the Dutch National Club, the NIOIC, in Alkmaar in 1996. And so, we acquire bidexterity due to routine bimanual exercises. BIMA in action. The spoon-shaped aspiration orifice functions as vacuum forceps. The equatorial cortex is aspired in an alternating way, in the radial and tangential direction. The diamond-powered tip with side port is handled in the same fashion. In so doing, we prevent stress and damage to the capsule and, most of all, to the invisible sonulae. The event of occlusion is always under your control, as can be seen here. The spoon-shaped orifices of the cannulas only slowly occlude. The piece of cortex is always visible and ready to be crushed and aspirated without the need of extra vacuum. Bimanual irrigation aspiration with routine phaco. You already have a digital controlled mechanical I&A system in your phaco unit. You only need a large non-reciprocative irrigation cannula to snugly fit the tunnel incision. It should almost be equivalent to the diameter and irrigation volume of your 2.6 or 3.2 mm phaco tip. Lastly, we take an aspiration cannula, which fits the side port and is around 50% smaller than the irrigation cannula. It is an asymmetrical procedure. There is no real indication for a second side port, which is only an extra trauma. The bimanual cannulas. The irrigation cannula is blunt, has an internal diameter of 1.2 mm and is slightly angulated. The aspiration cannula is also blunt, but spoon-shaped, and has an internal diameter of 0.7 mm. We can also use the widely appreciated rounded diamond powdered tip with the internal diameter of 0.7 mm with 1 or 2 side ports. The now widely accepted diamond-tipped side port cannula, seen in the centre, is also a very efficient irrigation aspiration device on condition that the anterior chamber inflow is well adjusted to the aspiration power. With these 3 types of cannulas, we can safely eliminate the entire cortex. BIMA cannulas are, amongst others, manufactured by Bosch & Lomb, Storz, and Medical Workshop. I have no financial interests in any of the materials presented. The BIMA tubing setup. The larger irrigation cannula is directly attached to the white male ending of the standard irrigation tubing. The aspiration cannula needs an extra metallic male-male adapter, which is put to the blue or green standard female end of the aspiration tubing. At the beginning of this new millennium, we switched to the Bosch & Lomb Millennium Phaco machine because of its unique separation of the phaco ultrasound power and the aspiration power, controlled by a 3-dimensional foot switch. Basically, the phaco ultrasound power is a forward repulsion force, in contrast to the aspiration power, which is an inward vacuum force. The dual linear dynamic mix of both gives us safety and efficacy. Nowadays, other brands have copied this advanced feature. The standard I&A settings during BIMA. The phaco unit should be set to the standard I&A levels of your personal choice. This system has a safe tolerance range. The vacuum is mostly sufficient at 200 to 300 mm of mercury. But you can increase it to 400 mm if needed. The flow rate ranges between 20 and 30 milliliters per minute for peristaltic systems, and the infusion height varies between 85 and 95 centimeters above the patient eye level at the start. One practical tip: instead of the metallic male-to-male adapter, you can use a short piece of the standard surgical radon drain number 12. Some results. This clinical survey was mostly carried out by Dr. Neo in 1993. In contrast to Dr. Binghorst and Dr. Vost, I did not publish regularly about the same evolving technique. My mission and commitment was cataract surgery in the field. Eventually, Arthur Stau and Kai Neo attended a kind of fellowship in my clinic in the mid-80s and 90s. And that was the beginning of their ophthalmologic careers. To sum up, first, bimanual aspiration irrigation of the subincisional hemicircumference. Secondly, monomanual coaxial aspiration of the residual cortex of the remaining capsular circumference with your own monomanual standard INA handpiece through your tunnel incision. Or alternatively, bimanual aspiration irrigation using an eventual second side port with a third incision, but I do not recommend this. Our next target is bimanual emulsification phaco. And so we move from routine bimanual handling to acquired bidexterity. We already went this way for many years. It's efficient and safe, and our scrub nurses love it, due to their constant surgical position with right and left eyes. Dedication. As a free fellow of Christ, in a world so in turmoil with confessions of hate and slaughter, I thank the peaceful Joshua, who is Jesus Christ, known in the Orient and Asia as Isa, for his accomplished work on the cross. Since 1972, Christ's accomplished work has made this development possible for me to share a modest, apparently useful contribution to our standard medical practice. And this is my acknowledgement. Never to be forgotten were these hands and feet along my ophthalmic pathway. This is meant as a kind of legacy to all my ophthalmic and cataract patients and those to whom I could pass on my knowledge, to share our mission in the medical field.